alaikum wa rahmatullahi wa barakatuh. Welcome everyone to week 5 of Basic Dermatology curriculum organized by Saudi Society of Dermatology and Dermatological Surgery. My name is Leen Alturki and I will be the session moderator today, inshallah. Firstly, I would like to thank you for joining us today. This session is being recorded and it will be made publicly available along the course content on the Society official platforms and on social media after the course completion. Today's session plan will include the main lecture delivered by Dr. Zeinah, followed by 5-minute scientific talk by L'Oreal. Please feel free to type your questions in the chat at any time, and we will address all the questions during the Q&A segment at the end of the session. Our session today will be delivered by Dr. Zeinah Alhalees, a Canadian and American board-certified dermatologist. She completed her residency training in dermatology and cutaneous surgery at McGill University in 2022. She subsequently completed a fellowship in immunodermatology at University of British Columbia in 2023 and earned a Master of Health Sciences degree from the School of Population and Public Health at University of British Columbia. She is currently working as a dermatology associate consultant at Department of Dermatology in King Faisal Specialist Hospital and Research Center, Riyadh. Thank you very much, Dr. Zeinah, for joining us today. It's our pleasure and honor to have you with us.
Thank you so much for the kind introduction, Leen. So today I'm going to be talking about dermatological emergencies, recognition and management. If any of you have, attended my talks before, I usually like them to be interactive because I feel like you learn more when it's interactive. So what I'm going to do is I'm going to do an introduction and then we're going to identify various dermatological emergencies. So feel free to unmute yourself to throw in the diagnosis or throw it in the chat box and I'll take a look at it. This way, I feel like you learn more, okay? So what are dermatological emergencies? Dermatologic emergencies, as Stephen Chen once said, they are the ones that if you miss the diagnosis, you end up with a lot more morbidity and mortality than necessary. And they range from either primary cutaneous disorders or severe systemic conditions with cutaneous manifestations. And that includes obviously your scars, so your severe cutaneous adverse drug reactions, your autoimmune connective tissue diseases and other autoinflammatory conditions, as well as obviously infections and environmental insults. So really there's a very vast majority of dermatological diseases that can present as emergencies. Obviously I won't be able to cover everything, but I chose the most important ones that I want you to be, hopefully by the end of this presentation, comfortable in diagnosing and managing, okay? So we want to do a prompt recognition of the emergency as well as appropriate diagnosis and treatment to improve obviously patient outcomes. So a single decision can mark the difference between life and death in these emergencies. So what are the clues that a skin rash is concerning? So obviously if the patient has fever, if the patient has systemic symptoms, if we have skin pain. So this is something I really want you to remember. Sorry, I just realized that my camera is not open. I'm just gonna open it. I like to have my video open so you can actually see my face when I'm presenting. Perfect. So skin pain. Skin pain is very, very important. And I want you to remember that this is an important skin symptom, okay? Epidermal detachment, obviously, mucosal involvement, blisters, and purpura. So those are all important signs that the rash is quite concerning. So let's start with the first case. When you see this rash on the patient's trunk, look at his face, what are you expecting? So what do you think this is? And you can feel free to write it down in the chat. I don't mind. You don't need to unmute yourself. So perfect. I see Aisha writing, I'm assuming SJS, and that's excellent. What's the difference between, exactly, some people wrote SJS-TEN, perfect. And this is what we're going to talk about. So why did you guys say this is SJS-TEN? Excellent, Aisha. So the body surface area of involvement differs SJS from TEN, and we'll talk about it in a bit in detail. But what was striking? Why did you guys jump to the diagnosis? And excellent, it's a spot diagnosis, and I want you to immediately recognize that this is SJS-TEN. So important clues in the examination is the perfect, exactly, excellent. So you can see the skin detachment over here. You can see the mucosal involvement. So more than 90% of SJS-TEN patients have mucosal involvement. Perfect. And I think someone wrote about the color Okay, nobody mentioned it, but basically the dusky erythema. And I want you to note that you look at this redness, it's not like your regular red. It's really dusky. And dusky erythema is not good because someone wrote exactly petechia-like, so it's like more grayish erythema. And that's concerning because that means that the skin is actually dying. So it's necrosing. So excellent, guys. Good job. So this is SJS-TEN, so Stevens-Johnson syndrome, toxic epidermal necrolysis, and both of them are acute bullous disorders, and they're a variant within a continuous spectrum. And that's when we said continuous spectrum because we're going to talk about the BSA in a bit. So they're rare, they're not quite common, and we know that certain patient groups are at higher risk. So who are they? It's a bit more common in females. Other risk factors include slow acetyler genotypes. So slow acetyler genotypes means that they their liver and doesn't clear out the medication as fast as other patients, and this is the genetic variation. Immunosuppression, so HIV patients, lymphoma patients. There's this specific one, which is concomitant administration of radiotherapy with anticonvulsants, specifically in those with brain tumors. And then obviously the important one is specific HLA alleles. So as you can see with HLA-B1502 in Asian, so specifically in Han Chinese, those have a higher risk to develop SJS-TEN from carbamazepine. And this is actually now in China. They actually have to screen for this HLA, so the B1502, before prescribing carbamazepine. And that's how important it is. Also 1502 with lamotrigine, with phenytoin, and then 3101 for carbamazepine in Europeans, and 5801 in Han Chinese for allopurinol. We also have a lot of other HLAs, but those are the common ones. So when does it occur? When does the skin rash occur? It usually occurs 1 to 3 weeks after initiation of the responsible drug. Most common drugs are your, as we just mentioned, your anticonvulsants or your aromatic anticonvulsants like carbamazepine, your allopurinol, NSAIDs, antibiotics as well. Those are all important. Out of all antibiotics, sulfonamides are the most strongly associated with SJS-TEN. So what exactly happens? What's the pathogenesis? And I think this is super important because it makes you understand the treatments that we use to manage SJS-TEN. So we talked already about individuals with particular predisposing factors, and they have the impaired capacity to detoxify the intermediate drug metabolites. And then what happens is that they mount an immune response against this neoantigenic drug tissue complex. Okay? So the drug tissue complex, from its name, basically it's made out of the drug itself and a tissue complex that we'll talk about in a bit. So what does this lead to? It leads to influx of T cells and release of cytokines. So important cytokines in SJS-TEN include IL-6, TNF-alpha, interferon gamma, IL-18, and Fas ligand. So those are responsible for the massive keratinocyte apoptosis that we see with SJS-TEN. We have basically the drug-specific CD8 cytotoxic T cells that are releasing perforin and granzyme and granulysin that lead to apoptosis of the keratinocytes. We also have interaction of the death receptor ligand pair, Fas ligand, that induces apoptosis in these cells. And then we also have drug-activated monocytes that release something called annexin A1, which induces necroptosis in SJS-TEN. So patients present with the prodrome of URTI-like symptoms, so fever, URTI-like symptoms, stinging in their eyes, and then within 24 hours, they start to develop, 24, 48 hours, the characteristic mucocutaneous eruption. So what do they have? Tender. Okay, so I want you to remember tender, so painful skin. Dusky red, this is an important one. So dusky red macules and patches with atypical, I think I saw someone who wrote it in the chat, target, but they get atypical target lesions. And what's the difference between atypical target lesions and true target lesions? Atypical ones are non-palpable. So they're macular targets, okay? And then later on, they develop epidermal necrosis with characteristic gray hue that I was telling you about, plus minus epidermal detachment and bulla, so you can get a positive Nikolsky sign. Mucosal erosions, as you all mentioned, we said that it's present in more than 90% of patients. So this is an important clue that differentiates SJS-TEN from other drug eruptions. And then obviously with severe SJS-TEN, so more with TEN, you can get respiratory and GI epithelium involvement in about a quarter of patients. So the measurement of body surface area is important. We need to include not only the detached skin, but the detachable skin as well by positive Nikolsky. Or you can look at the gray skin. This skin, you know, is an impeding detachment, basically. If it's less than 10%, I think Aisha already mentioned it, then that's SJS. If it's 10% to 30%, this is SJS-TEN overlap. And if it's more than 30%, then this is what we call TEN. And actually, palms and soles can be an early site of involvement, as you can see with this patient. So this is what we just mentioned about the clinical presentation, but we always have to, after we look at them clinically and diagnose them, obviously it's a clinical diagnosis, but you want to do your score 10 as well, and you want to do your biopsy later on. So on your first initial presentation. So your score 10 calculates basically the severity of illness in a TAN patient. And what does it do? It predicts the mortality rate. They tend to ask you about the components in exams. So the way I remember them is you have 2 history, 2 physical exam, 3 labs. So these are the components. Your 2 history is age above 40, and then cancer history or hematological malignancy. Your 2 physical exam is your heart rate above 120, and your BSA on day 1, the initial presentation of more than 10%. And then your labs, you have your urea level, bicarbonate, and glucose. Sometimes they actually, if it was an oral station, they may ask you about the number. So the urea is more than 10 millimole, the bicarbonate is less than 20, the glucose is more than 14. And out of all of them, which one is the most important? That is like the predictor of like higher mortality, or it's like it's a bad sign out of all labs. Bicarbonate. Excellent. Good job, you guys. Excellent. Aya and Ahmed, good job. Where did we reach? Okay, so after the score 10, we also have other factors that are related with poor outcome, which actually kind of makes sense, right? So it's your increased age, your increased number of medication, late withdrawal of the drug. So anytime you delay the withdrawal of the drug, you increase the risk of death by 30% per day. So that's a huge number. Obviously, extent of epidermal detachment, if the patient has neutropenia, lymphopenia, or thrombocytopenia, and then if you have, like we just mentioned, elevation in your urea, creatinine, and glucose levels. So diagnosis. Diagnosis is clinical. You're not going to wait for the biopsy, obviously, right? You see the patient, you know this is an SJST, and you do the biopsy just medico-legally, obviously, and to confirm your diagnosis later on. But you're not going to wait on the biopsy before managing the patient. So once you do the pathology, you can see with your early lesions, you can have apoptotic keratinocytes that are scattered in the basal and suprabasal layer of the epidermis. But with later stages, you're going to have your confluent necrosis with a sparse perivascular infiltrate, and this differentiates it from EM major, right? So with EM major, you have more perivascular lymphocytic infiltrate, and this is how we differentiate SJS-TEN from erythema multiforme. What is this? So you also have mucosal involvement, but look at the palms. What do you see? For some reason, I can't open the chat. There we go. Perfect. So we see a true target lesion, and which is EM major. Excellent, you guys. Good job. So some people are saying target, some people are saying targetoid. It's actually a true target lesion. Why? Because one, it's 3 zones. So you can see 1, 2, 3 zones, your central dusky, your surrounding white, and then your surrounding dusky erythema. The other thing that I palpated the patient, so it was actually a palpable target lesion. And it's this is your most important differential diagnosis, obviously, for SJS-TEM, right? So it's erythema multiforme major, and it's a distinct disorder from SJS-TEN with different clinical signs and different precipitating factor. So you're going to see some dermatologists lump them all in one diagnosis, but majority actually separate them and don't consider them the same entity. So most people consider SJS-TEN as true drug eruptions, and EM is mostly your trigger is going to be HSV. Very rarely it's medications. So why are we saying it's a distinct clinical order in terms of for the primary skin lesion and distribution? Because with SJS-TEN, we said it's a targetoid lesion or an atypical target. With EM, it's a true papillary target lesion. Sometimes it can be atypical, but you're going to still have the palpable target lesion and obviously the distribution. So it's going to be more acrofacial, hands, elbows, knees. And in terms of mucosal involvement, both of them have mucosal involvement. Precipitating factors in SJS-TEN, it's drugs. In EM, it's usually HSV. So that's the most common precipitating factors, but you also have other infections like Mycoplasma pneumoniae, plus the prognosis. SJS-TEN is dangerous. It's an emergency. It requires prompt withdrawal of the medication and aggressive treatment. With erythema multiforme, if it's minor, really it's self-limited. If major and it has severe mucosal involvement, then you can do systemic treatments. And just remember, it does not carry a progression to TEN. So it's a distinct disorder. You can do supportive care. You can treat with prednisone and treat recurrences with antivirals if you know that you have HSV as a true precipitating factor. And this is one of the tables in Bologna that I really like. It just shows you the differences between EM minor major, SJS, SJS-TEN, and TEN overlap in terms of the primary skin lesion distribution, systemic symptoms, and the triggers as well. So I'll keep it for you later on to read. Okay, back to SJS-TEN. In terms of management, the most important step is early diagnosis, immediate discontinuation of causative drug and all unnecessary drugs, and you want to do rapid supportive care. Okay, so this is your mainstay of treatment. As I mentioned, you want to calculate the score 10 within 24 hours. You want to do your investigation, so skin biopsy, CBC, UNE, LFTs, glucose, all of your labs, so your urea, bicarbonate, etc. If you're, suspecting, let's say, mycoplasma and MRM, you can do your mycoplasma serology and chest X-ray. And you also want to do a septic workup, okay, baseline septic workup. This is all supportive. Basically, your most important thing is to stop the drug. And obviously, it's a multidisciplinary team approach. So you want dermatology, but also you want ICU or burn unit involved. And then depending on ocular involvement, genital involvement, so you want ophthalmology, gynecology, etc. So in terms of supportive care, we either want to admit them to ICU or the burn unit, especially when their body surface area is above 10 to 20%. You want to give them controlled pressure, thermoregulated bed, hydrate with IV fluids, nutritional support, analgesia, PPIs, DVT prophylaxis, all of that is super important. Venous catheters should be placed in a region of non-involved skin. You want to try as much as you can. You want to do careful daily wound care and limit patient manipulation, and we'll always write that in the chart for the nursing team. We want to keep the non-detached areas dry, and detached areas should be covered with Vaseline gauze until reepithelialization occurs, which occurs around 2 weeks. In terms of orifices, you want to clean them with NS and you want to apply antibiotic ointments. So nasal mucosa, oral mucosa, as well as genital mucosa, and you want to swab periodically for bacteria and candida from the crusted skin lesions on alternate days. Again, don't forget to consult ophthalmology. They may use ophthalmic antibiotic ointments as needed. And then there is something called the embryonic membrane, which they can use on eyes, and it can help the cornea prevent the cornea from scarring, basically. So they can sometimes help with that. Urology, gynae, you want to apply Vaseline to the urogenital area. Urinary catheter obviously is important as well to prevent urinary retention and infections and scarring as well. And you also want to consult ENT and RESP, depending on the patient's, also like GI if they can't swallow, so depending on the patient's presentation. In terms of systemic treatment, so far we don't have any prospective proven efficacy based on prospective clinical trials. So what we have obviously is all retrospective, and it makes sense, right? Because no one's going to study prospectively TEN patients, unfortunately. So in terms of treatment algorithm, right now the recommended algorithm actually is cyclosporin and TNF-alpha inhibitors. So if you can see that IVIG and corticosteroids have been pushed downwards. Cyclosporin can be given from doses of 3 to 5 milligrams per kg per day split BID. And this was reported to reduce mortality by around 60%, comparing patients with similar score 10 on admission that did not receive cyclosporin. So it clearly does work. And compared to IVIG also, the mortality ratio was lower for cyclosporin patients. In terms of TNF-alpha inhibitors, so you can either use Enbrel, etanercept, or infliximab. This is first line if cyclosporin is contraindicated. So you can give them a single dose of etanercept at 50 milligrams sub-Q, and you can actually repeat it at week 2 if needed. But why don't we give IVIG as much anymore? So the concept is, remember when we were talking about fast ligand in terms of cellular death? So this is what IVIG does. It goes and it blocks fast ligand to fast. However, in studies, it was shown that there was a significant lack of consistency of efficacy within IVIG, and that's why we don't tend to use it as a first line. How about corticosteroids? So you can either give them IV dexamethasone or methylpred, followed by an oral taper. prednisone. So this remains controversial. And the reason is the concern was the increased risk of infection and sepsis, plus the impaired wound healing. So they have a lot of detached skin and you may delay the reepithelialization. Plus, in studies, there was no proven benefit in mortality. So that's why it also has been pushed downwards. Other treatments that possibly can be used, honestly, we don't tend to use them. Cyclosporin, plasmapheresis, and neutropenic patients may benefit from GM-CSF. But obviously, this is all like this is with ICU. So what is the average mortality? The average mortality in SJS patients can reach up to 5%, in TEN patients up to 35%. So they tell you almost on average, a death occurs in every third patient with TEN. So really, this is your major emergency that you have in dermatology. And obviously, why do they die? Most commonly, it's due to infections, so sepsis. You have an impaired skin barrier. A lot of microorganisms can go through the skin into the bloodstream, and patients can die because of that. And they can also have transepidermal water loss with electrolyte imbalance, inhibition of insulin secretion and insulin resistance, hypercatabolic state, so they become cachexic, and ARDS, so adult respiratory distress syndrome with multi-organ failure. So these are the causes of death, but number one is sepsis. So if you're going to get any exam question, it's going to be sepsis. Later on, they heal through reepithelialization, usually starts within days, completes around 2 to 3 weeks. However, you may have long-term sequelae. So cutaneous ones, usually it's scarring. They can get a little bit of scarring, dyspigmentation, eruptive melanocytic nevi, nail dystrophy, and alopecia. In ocular, so they can also get symbliphron, conjunctival synechiae, entropion, and ingrown of the eyelashes. Urogenital, they can have urethral stenosis, phimosis, vaginal synechiae with dyspareunia and hematoculpus. Obviously, those are in severe cases. Okay, moving on to case number 2. What do you think this is? Oops, sorry, guys. Okay, I'll just go ahead. So, wait, why do you think this was dressed, Tayyib? I'll just ask you those questions. Okay, someone already actually, I think it's Ayat. She already mentioned it's dress. And then I'll answer like the other questions, like what is the difference between targetoid by the end of the presentation. Perfect. So I can see that you have the facial edema, the maculopapular rash. Perfect. So morbilliform rash and facial edema. Excellent, guys. So this is DRESS. So what is DRESS? Drug reaction with eosinophilia and systemic symptoms. So what happens with DRESS? DRESS is also considered a multi-organ scar, so a severe cutaneous adverse drug reaction, and it occurs around 2 to 6 weeks after the initiation of a drug, usually. So the drugs are quite similar in general for all of them, for morbilliform, for DRESS, for SJS, so you have your aromatic anticonvulsants, so carbamazepine, phenytoin, etc. You have your allopurinol, as well as your antibiotics. Again, sulfonamides are important, but you can have dapsone, minocycline, etc. So what happens exactly? So it's a multifactorial type 4 T-cell mediated hypersensitivity reaction. So you do have specific HLA alleles that are important genetic risk factors. So similar to SJS/TN, we have, for example, HLA-B1303 and dapsone in Han Chinese. You also have genetic polymorphism that affects detoxification. So like we said, slow acetylers. You also have genes that affect detoxification. So your arene oxide metabolites in anticonvulsants won't get detoxified. And then you also have, there's this whole talk about reactivation of viruses like your human herpes virus 6 and 7, CMV, EBV, which may also lead to this T-cell mediated hypersensitivity reaction to drugs and drug metabolites. So what happens in general? They get a polymorphic rash. So usually it's a morbilliform. It's a maculopapular, like what you all said. A clue is follicular accentuation. So the rash is accentuated a little bit more around the hair follicles. They can have also anything because it's polymorphic. So they're allowed to have pustules, they're allowed to have vesicles and bullas, so they can get anything. And sometimes they can even have mucosal involvement in around 25% of the patients, and they develop facial edema. So this was your clue that this was a dress. And honestly, it was a Chinese patient too. So, and he got allopurinol, to be honest. So that was a little bit of a clue as well that this is that this was dress. From its name, so it's a drug reaction with eosinophilia and systemic symptoms. So they have systemic symptoms. So they have fever, lymphadenopathy, and they can get internal organ involvement. So basically, I always say any itis. Common ones are common, so they get hepatitis, so liver involvement is common, as well as nephritis, so those are common, but they can get myocarditis, pneumonitis, myositis, thyroiditis, literally any organ can be infiltrated by EOs. It can persist weeks to months. And you can also have additional sites of involvement later on, several months later, specifically cardiac and thyroid. And that's why it's important to get a baseline thyroid function test and a baseline EKG to compare it months later. Because if they develop a thyroiditis, you actually have a baseline level of their thyroids before this or as soon as all of this stress happens. How do we diagnose it? Clinically, we do have scoring systems like the Reggie scar, the J scar that tells you if it's a possible, probable, etc. And then obviously you want to do labs. So you want to look at your eosinophilia, you want to look at your atypical lymphocytes, and then obviously your liver and renal involvement. So those are important, as well as the reactivation of your HHV6, 7C, MV, and EBV. You can do a biopsy, but your biopsy is usually not very specific because it can present with a lot of different patterns. So it's actually a supportive biopsy rather than a diagnostic. So you can have either an exanthematous pattern, interface dermatitis pattern, which is the most common one. You can have AGIP-like, EM-like. So really it's different. Why is it important to recognize? There is a little bit of an associated mortality, so up to 10% in patients with DRESS. The most important thing with DRESS is obviously early recognition of the diagnosis as well as early withdrawal of the offending drug. So this is your most important step. We still don't have guidelines for treatment. However, corticosteroid systemic ones remain the first-line therapy with a slow taper. And why do I say a slow taper? Because we said it can persist months to weeks. So we don't want to rapidly taper their steroids and then they get a flare of their DRESS. Other things that we can use, so cyclosporin. Some people use antivirals, however, we don't have strong evidence, and the reason is because of this HHV6 and 7 reactivation, and that's why they use it. But we only have case reports and series, and IVIG is not favorable. Long-term sequelae over here in DRESS, it's usually autoimmune sequelae. So they can get alopecia areata, vitiligo, so these are the skin involvement, but they can also get, as we mentioned, thyroiditis and myocarditis. Those are the important ones. Okay, how about this patient? Let me know what you see and what do you think the diagnosis is. Okay, so I see AGIP. That's a good differential. I think the picture is not too clear. If I tell you that these are scales, these are not pustules, what would your... Perfect, Faisal. Good, so I see erythroderma. And why did you say this is erythroderma? Excellent, Ola. AS, I don't know who that is, but perfect. Good job, you guys. Good, Faisal. So it's erythema and exfoliation. And this is the exactly. So red and scale, so erythema and exfoliation or scales, more than 80% of the body surface area. Excellent, guys. So this is the definition of erythroderma. You don't need me for this talk. MashaAllah, you guys are doing great. Okay, so what is erythroderma? It's a widespread erythema and scale. A scale is around 20 to 30 grams of scales or skin per day that affects more than 80 to 90% of body surface area. So we obviously have adult and pediatric forms in both either primary or secondary forms. What happens? So in primary, this is your idiopathic. It can be seen in around 1/3 of erythroderma patients, and usually it affects 50-year-old males more commonly. And there's a possibility role of this age-related immune senescence. Secondary usually results from everything. There's a huge table in Bologna that tells you all of the diseases that you can present with, but you have ones that are more common in adults, ones that are more common in pediatrics, and I want you to know those because this is how the exam, usually the oral exam question comes. So in terms of adults, you have idiopathic as a more common one, and then you have eczemas in general as a whole category. But when you go to a disease, so psoriasis is actually one of the most common causes for erythroderma, followed by atopic dermatitis. And then you have drug eruptions, which is the third one. And then you have other diseases like cutaneous T-cell lymphoma and Sézary, as well as autoimmune blistering disorders, such as pemphigus foliaceus, more commonly than other blistering disorders. And then you have the more rare ones, such as PRP. Pediatrics, don't forget that you have your genetics, like your ichthyosis and things like that, okay? So what happens with erythroderma? You have an increased number and increased mitotic rate of your germinative keratinocytes, plus a short transit time throughout the epidermis, and that's why they shed these scales very, very quickly. So clinical presentation, as we just mentioned, erythema, scale, and pruritus. So the most common symptom that they get is usually itch. Later on, as the erythroderma becomes more chronic, you can have lichenification, dyspigmentation, you can have PPK, so palmoplantar keratoderma, and they can develop alopecia. Their nails later on tend to become shiny. Usually it's from scratching their skin. It's like you're using a buff on your nails and then it shines. So this is what happens with their nails. But later on, they can also develop nail dystrophy, and other signs give you clues of underlying disease. So if they have pits, if they have subungual hyperkeratosis, obviously you're thinking of psoriasis. So you want to look at the different findings. Purulent conjunctivitis is one as well. They can develop SKs later on. And an important thing is that they tend to have Staph aureus colonization. So they may develop secondary cutaneous lesions. Erythroderma patients usually have systemic symptoms. So they're losing a lot of, so you have a lot of this transepidermal water loss, as well as heat that's being lost from the skin. So they may have facial edema, lymphadenopathy. Lymphadenopathy is the most common systemic symptom. And then they can develop, because of the hypoalbuminemia, they can develop peripheral edema, obviously hypoalbuminemia, fluid loss, tachycardia, electrolyte imbalance, thermoregulatory disturbances, and high output cardiac failure. Later on, they can develop sometimes ARDS and hepatosplenomegaly, especially with the drug-induced ones. And chronic, the more chronic it is, the more cachexia they become because of all of this, and they can also develop anemia and ectropion. So erythroderma, you really have to dig in with history and physical exam, because that's going to give you a clue if it's primary or secondary. So you want to look for your secondary causes, and you want to do your investigations based on your clinical suspicion of your underlying disorder. So all of them obviously need a baseline workup of CBC, LFTs, renal, etc. They do need a skin biopsy. You can consider DIF as well. And then obviously when you do your biopsy, also you want to do your immunohistochemical stains if needed, your T-cell clonality in the tissue, so in your skin biopsy. And then you also want to look at their lymph nodes. If they do have lymphadenopathy, you want to do biopsy of the lymph nodes, and you want to stain that as well to make sure that it's, is it involved? You want to do TCR from the blood as well, and they may need a CT cap as well, the chest, abdomen, pelvis, or a PET CT. In terms of management, so obviously they need a supportive care, nutritional assessment, hydration, etc., all of that. But you also want to treat the underlying etiology. So in terms of treating underlying etiology, obviously I'm not going to go to each and every one, so psoriasis, eczema, etc., but we're going to talk mostly about the idiopathic erythroderma. So once we rule out all other causes, you want to treat them with bland emollients. You can use low potency corticosteroid ointments. You don't want to give them really super potent ointments, but with lichenification, you can give them mid to high potency corticosteroids. You also want to give them PRED, so usually 1 to 2 milligram per kg per day initially, and then you can taper it down to 0.5 milligram per kg per day or less, and you want to taper it slowly up until you try to find your diagnosis. If you don't find the diagnosis and you diagnose the patient as primary or idiopathic erythroderma, obviously you don't want to keep them on steroids for a long time. So that's when you can actually switch them to cyclosporin. Cyclosporin would be a good option unless you were considering cutaneous T-cell lymphoma. So you want to avoid that, and you can use other things like methotrexate. The best empiric treatment would be methotrexate, actually. So how about this patient? Over here, you can see the pustules, right? They're more clear than the previous picture. Okay, so I see that people are seeing AGIP. What other differentials do you have? An important differential other than AGIP. DRESS is an excellent one, perfect. And pustular psoriasis, excellent, perfect. Acute pustular psoriasis, excellent, you guys, very good. Okay, so this was actually AGIP, and we based it on, honestly, history mostly, but we're going to talk about a few features that differentiate AGIP from pustular psoriasis in a bit. So what is AGIP? Acute generalized exanthematous pustulosis. It's a severe acute pustular drug eruption, and it's a type 4 hypersensitivity reaction, to 4D T-cell mediated hypersensitivity reaction. How do we diagnose it? Usually it's a rapid onset of rash after initiating the medication, less than 4 days. Usually it's between 1 to 3 days of drug exposure, and most commonly it's your beta-lactam antibiotics as well as your macrolides, but you also have calcium channel blockers as well as anti-malarials. So what happens clinically? You have these numerous, small, so less than 5 millimeter, non-follicular sterile pustules, usually on an erythematous base, as you can see over here. It begins on the face and intertriginous areas. So these are the common places, and then it tends to generalize, and it's often accompanied with systemic. So far it really resembles psoriasis. So fever, leukocytosis, and neutropenia. Lesions resolve with desquamation, usually 1 to 2 weeks after drug withdrawal. It may involve mild cutaneous erosions. So this is your clue. If you have a drug history, and sometimes if you have mucosal involvement, usually this can be associated. This is usually more Egypt rather than psoriasis. Another thing is obviously your personal history of psoriasis, and on physical exam if you have other signs of psoriasis, scalp involvement, nail involvement. So you really want to look at those on history and physical exam. So in terms of diagnosis, mostly it's clinical. So it's a clinical recognition of your acute pustular eruption plus the drug timing. Labs can help you out. So leukocytosis with neutrophilia mostly. And then if you do your biopsy. So really skin biopsy here can easily help you differentiate Egypt from psoriasis. And this is a question I always ask my residents when they are rotating or with me in clinic. So how do you differentiate Egypt from psoriasis on skin biopsy? Do you guys want to throw a few in the chat? Just give me 2 or 3 differences between them. And this is actually a very important exam question. Good. So you see more eosinophils with Egypt. Excellent. I think Egypt is a drug reaction, right? So what can you have also? Yes, so you can have more acanthosis with psoriasis that we don't see with prolongation of the lead ridges. Usually, though, this can be with long-standing psoriasis. But if it's an acute pustular psoriasis, you may not have a lot of acanthosis. And parakeratosis that you see more with psoriasis. Good job. Neutrophils with both of them, right? So both of them are going to give you subcorneal pustules and intraepidermal pustules in psoriasis. But think of Egypt. Egypt is a drug reaction, right? So you're going to have more eosinophils. You can have an interface dermatitis and more lymphocytic infiltration. This is another one. And you can sometimes even have an associated vasculitis, and you can have necrotic keratinocytes. So these are your 4 clues that this is more Egypt rather than psoriasis. Okay, now think it's a drug reaction, right? So you have and spongiosis actually. So you can see more spongiosis with Egypt that you don't see with psoriasis, and you can see subcorneal intraepidermal pustule with neutrophilic infiltrate and the things that I just mentioned. But your most important differential diagnosis is pustular psoriasis, and you guys mentioned DRESS, which is excellent. You can throw in SJS and your management, you want to obviously you want to initially diagnose it, and then you want to withdraw the offending drug, all unnecessary drugs, and then usually it's supportive care. You can actually treat them with topical steroids if they're not too bad, or you can give them short courses of systemic steroid in severe or if they have systemic symptoms, and then obviously they tend to desquamate. And then after desquamation, the skin tends to de-epithelialize within around 2 weeks, usually self-limited once the drug is stopped, and you just want to avoid re-exposure. How about this one? So you guys already did mention it as part of your differential, but you can see here you actually have more lakes of pus, right? So with Egypt, they were really non-follicular pustules on an edematous base. But over here, you have a little bit more of these lakes of pus. So excellent, you guys. This is pustular psoriasis, right? So if I say you have systemic symptoms, so what type of pustular psoriasis are you thinking of? That's an emergency. Generalized pustular psoriasis, von Zumbach type. Good job, Mohammed. Mumtaz. So, generalized pustular psoriasis von Zumbach type. So, it's a rare, severe form of pustular psoriasis. patients have recurrent flares of widespread sterile pustules on an erythematous base, and they can actually even have painful skin over here. And they have systemic symptoms, so often fever. They can have hepatic involvement, GI involvement, musculoskeletal. So they can tell you that they have a little bit of joint pain. They feel fatigued, but they can literally have any organ involvement. So what happens? Usually they have an unregulated IL-36 signaling. Obviously, some patients do have genetic predisposition, so they can have the homozygous IL-36 receptor gene mutation or CARD14 mutation as well. But they can also have environmental triggers, so exactly like psoriasis, that can, plus other things like medications or abrupt withdrawal of corticosteroids or cyclosporin or vaccinations. That can lead to the unregulated IL-36 signaling. So clinical, we just mentioned it. So they have these recurrent acute flares, erythematous pustules, usually very small, 2 to 3 millimeters, sterile, non-follicular pustules that form lakes of pus. And this is how it's a bit different from AGIP. They can also have an associated geographic fissured tongue that we don't see with AGIP. And systemic symptoms is quite similar to erythroderma. And then you have your 2018 Japanese guidelines to diagnose acute generalized pustular psoriasis. So if they have four things, if they have systemic symptoms of fever and fatigue, excessive erythema plus lakes of pus, if they have on biopsy neutrophilic subcorneal pustules and spongiform pustules, and then if they have a recurrence of these clinical and histopath findings. So all four features will give you a definitive diagnosis, and then 2 to 3 is a suspected diagnosis of GPP. Why is it an emergency? Because it is associated with a mortality rate of about 3 to 7%. Obviously, once you diagnose it, initially you want to do supportive care, similar to erythroderma, and then same thing with treatment. So initially, topically, you can do corticosteroids, so mild to moderate all over the body, and then you can also give them systemic corticosteroids. Systemic corticosteroid is something temporary. Obviously, you want to initiate them on treatment later on. So nowadays, we don't tend to use a lot of, methotrexate and oral retinoids and things like that. You can either give cyclosporin or corticosteroids depending on if they have, if you are okay with giving them cyclosporin. I usually prefer that over steroids. However, you can give either or depending on what you are allowed to give in this patient. And then you want to start them on biologic therapies. Often we can give IL-17s, IL-23s. Those are good options. They do take time to work, and that's why we usually tend to treat the GPP initially with faster agents like steroids and cyclosporin. And now we do have an IL-36 receptor antagonist, so spesolimab, that has this recent FDA approval for GPP as well. And we have another one called imsidolimab that is currently under investigation for GPP. So this I'm just going to go over quickly. So Staphylococcal scalded skin syndrome. So SSS or quadruple S is considered one of our emergencies, pediatric emergencies as well. It does occur in infants and children, but you can see it in adults as well. So usually you see it in adults with CKD. And because they don't have the ability to clear the toxins via the kidneys, and or they lack the toxin neutralizing antibodies. So quadruple S, from its name, it's caused by phage 2 strains of Staph aureus that produce your ETA and ETB, so your exfoliative toxin A and B, which are serine proteases that cleave desmoglein 1. So resembling which autoimmune disease? Your pemphigus, right? So your pemphigus foliaceus. And then you have disruption of your epidermis at the granular layer. So clinically, you have the fever, irritability, skin tenderness. Obviously, with children, it's a little bit more difficult to assess skin tenderness. And then they can have this purulent rhinorrhea and purulent conjunctivitis, which suggests an underlying staph infection. And then on the skin, you're going to have erythema. Usually, it starts in the head and intertriginous regions, and then it starts to generalize within 48 hours. And then they have this wrinkling appearance of the skin, and they can have a positive Nikolsky sign with flexural exfoliation. So they have this characteristic peri-orificial crusting and radial fissuring without any intraoral lesions. And this is an important differentiation from SJS, and so they don't have intraoral mucosal involvement. Diagnosis is often clinical, but you can have histopath that's supportive of your diagnosis, where you have a split at your granular layer with a lack of dermal inflammatory infiltrate because it's quite fast and it's toxins, right? So similar to SJS, and mortality rate less than 4% in children. However, in adults, it's actually a bad disease. So your mortality can reach up to 60% in adults. Management, obviously, severe forms require hospitalization and supportive care plus antibiotics. So usually beta-lactamase resistant antibiotics. You can also use clindamycin with your beta-lactamase resistant antibiotics to reduce the bacterial toxin production itself. So they're often combined, and it can, but up to 50% of strains can actually be clindamycin resistant. So you just need to know that. So monotherapy is not recommended. It's usually added to your beta-lactamase resistant antibiotics. How about toxic shock syndrome? The toxic shock syndrome is an acute multisystem disease caused by either your Staph aureus exotoxin, so TSST1, or your so your Staph aureus toxin, or your, did I write it? Yeah, strep over here. So your strep TSS. And we're going to talk about the difference between both of them. So what is it basically? It's a virulent toxin that produces, oh, sorry, I wrote both of them here. Yeah, so you have either your staph toxin or your strep toxin. So your staph toxin is your Staph aureus exotoxin, so your TSST1, and then you also have your streptococcal toxin, so by your group A streptococci, which give you your SPEs, ABC, and the more potent SMEZ toxin. How do you get your staph TSS? So often foreign bodies and occult infections predominate. However, with your strep TSS, it's usually invasive soft tissue infections that give you this toxin. So often necrotizing fasciitis. Plus, majority of patients are usually bacteremic with strep. So toxins, what happens? They act as super antigens that bind to your MHC class 2 molecules of antigen-presenting cells and the VB region of the T cell receptor, leading to an hyperinflammation, so a cytokine storm actually in response to these bacterial superantigens, which leads to the production of cytokines like TNF-alpha, IL-1, and IL-6. So mostly more of a cytokine storm from your innate immune response. And this table shows you the differences between your staph TSS and your strep TSS. And these are the CDC case definitions for each. So the CDC case definition of staph TSS, usually you have the presence of 5 criteria. So you want to have a sudden onset of fever. You want to have a hypotensive shock. You can have a diffuse macular erythroderma, skin shedding, and involvement of 3+ organ systems, either the mucous membrane, which they actually consider it as a separate organ system than skin, your GI, MSK, CNS, renal, hepatic, or hematologic. In terms of strep, you actually have to have the isolation of your group A streptococci with hypotension plus 2 clinical criteria. So either a generalized erythematous macular rash and desquamation. Usually, it's much less often than in staph, by the way, the erythroderma that you see. And then you can have soft tissue necrosis, renal impairment, liver or ARDS, and coagulopathies as well. So diagnosis, as you guys can see, is mainly clinical, but the pathology is supportive. So they can have spongiosis in the papillodermal edema, plus exocytosis and infiltration of neutrophils and lymphocytes. Usually, obviously, they require intensive monitoring and admission and supportive care. You want to control the source of infections. So this is very, very important. So if they have foreign bodies, you want to remove them. If they have abscesses, you want to drain them. If they have necrotizing fasciitis, you want that to be treated. And then you want to treat them again with beta-lactamase resistant antibiotics along with clindamycin for the antitoxic effect. And you can also give them IVIG to neutralize the toxins, and this may have some added benefit. I think this might be the last slide. So what do you think the diagnosis is, and based on what? Perfect, Faisal. So purpura fulminans. And why do you say that? Necrosis of the digits. Excellent. So you can see digital necrosis, and obviously over here you can see purpura, right, on the skin, which is it's a non-palpable usually purpura. due to extravasation of your RBCs. So this is your purpura fulminans. So what is purpura fulminans? Purpura fulminans is an acute purpuric rash characterized by coagulation of the vasculature. So usually I say it's like DIC, but it's DIC in the skin. It's a complication of different serious and life-threatening diseases. So remember when I told you initially that in our dermatological emergencies, we may have ones that are primarily cutaneous, so like the ones that I just mentioned, SJS, TEN, DRESS, Egypt, von Zumbach, pustular psoriasis, but we can have those that are actually secondary to an internal disease, and this is one of them, right? Purpura fulminans. So your skin is just a sign to an underlying serious systemic illness rather than a disease entity itself. So we actually have three different types. We have the neonatal, we have the idiopathic, and then we have the acute infectious one, which is the most common one that we see in hospitalized patients. Often it's gram-positive and negative septicemia. But you can also have meningococcemia, Rocky Mountain spotted fever, quite rare in the region, and typhoid fever. So what exactly happens? You have the cutaneous microvascular thrombosis and hemorrhage. Remember, so I told you it's like DIC in the skin. Okay, so all types involve dysfunction of your hemostasis with a shift towards an overwhelming procoagulation. So initially you have an uncontrolled activation of your clotting factors in the blood vessels, but later on you deplete the platelets and the coagulation factors, so you lead into bleeding. There's a paradoxical increased risk of bleeding with purpura fulminans. So what are your clinical manifestations? So they're usually not well. They're sick, they're febrile, they're hypotensive, and they tend to have systemic DIC actually. And on examination, as you guys mentioned, so they have these irregular, well-defined extensive purpura with bluish digits, so fingers and toes. They become necrotic later on from the microocclusion, and then they develop subsequent hemorrhage and gangrene into the skin. Plus, they can actually have active bleeding from their skin and mucous membranes. So diagnosis is usually history and physical exam. Obviously, you really want to recognize this early, and then you want to determine the underlying cause. So for example, in neonatal, you want to make sure that they have normal levels of antithrombin 3. You want to look at their protein C, protein S. You want to do a full infectious workup with a full septic screen to rule out infectious causes of purpura fulminans. You also want to always check for DIC. Management is obviously supportive care. It's usually managed by ICU. They want to treat, they want to identify and treat the underlying disease. Anticoagulation obviously may be started to prevent further necrosis. Plus, they may need replacement of blood products and factors like platelets because those are depleted, right? So it pushes them further into DIC if you don't manage that. So in terms of derm, you're mostly aiding in the diagnosis rather than actually doing much in terms of treatment. Specifically, meningococcemia, we know that it's caused by Neisseria meningitidis. It's one of the causes of your acute purpura fulminans. The reason I'm mentioning it, because I think out of all purpura fulminans, so this is one of the things that we see, especially with Hajj and the people coming from outside, and that's why we vaccinate. Obviously, we get the vaccine to prevent from meningococcemia, especially during Hajj period. So it can be seen in up to 10 to 20% of patients, and as we just mentioned, so they have an acute onset of a particular rash, and they also get a disorientation, and then later on they start to progress purpura fulminans. Usually the lesion starts in their elbows and knees, and then it tends to spread elsewhere, and obviously it can lead to death. So any febrile patient with a particular rash and you're suspecting that they have meningococcemia, so you really want to treat them promptly after getting your blood cultures because their mortality rate can go up to 50%. Usually you want to do supportive cares and antibiotics, so carbapenems or vancomycin with beta-lactamase resistant antibiotics. So those are your important ones, and you can also add clindamycin as well. And IVIG can possibly help with neutralizing the toxins in meningococcemia. So take-home messages, dermatological emergencies do exist, on the contrary of what a lot of services believe. As residents, I think it's very important for you to recognize these dermatological emergencies because the cases can sometimes just evolve very, very quickly and become lethal. So I want you to be comfortable and confident knowing them and diagnosing them initially, and then obviously later on appropriately managing these patients. And always keep in mind that you want to collaborate with other departments. So you mostly always need ER, you may need ICU, burn unit, internal medicine, infectious diseases. So you're not really the sole treater in majority of these cases, but you are actually you're like it's like an orchestra, and you're leading this orchestra as a dermatologist. And these are my references.